Test, test, 1, 2, 3. Test, test, 3, 2, 1.
Good morning, everybody. The Finance Committee will come to order. Thank you all for being here this morning. Let's dive right in. Are there any citizens signed up to address the committee this morning?
No, Steve, nobody signed in.
Thank you, sir. All right, we'll move to item 3, which is approval of the minutes from the August 27th Finance Committee meeting. I'll entertain any motions for passage or amendments.
This is Zim, move to approve. Steve, this is Charlie, I'll second.
We have a motion and a second. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, everybody. Move to item 4, the CFO report. Ms. Clark.
Always a struggle. Sorry about that. I had muted myself. Good morning. You know, I don't have much to report this month. I just did want to remind everybody that we are closing our year in a couple of weeks. September 30th is upon us. For you new board members or newer board members, just a reminder that we don't have a calendar fiscal year. We actually go 12 months ended September 30. So I do want to prepare you for some large entries at year end. We've already talked about them through the budget process, but we did receive a very large UC payment, uncompensated care through the waiver program. And that will be recorded at year end. That will be about $90 million. And then we also are dealing with COVID recognition. We just received some of the guidance on what can be included, and we'll be working with BKD to record that appropriately. So more to come next month on that.
Any questions for Sharon? Okay, before we move on to the matters of discussion and action, I want to update on a couple of quick things. Trent and I have been discussing, and for our October 22nd meeting, in addition to the year-end discussion that Sharon spoke of, we're going to have a joint planning and finance committee meeting to discuss the enterprise risk management issues. And so I think it's got obviously a significant financial component to it. So we're going to have that. I hope everyone can join us. I think it'll be a pretty important discussion. And also just want to let everybody know our audit process is underway. I had an opportunity to meet with our visit online with Chris Clark, who is our auditor. And that's, I think, part of his process is he does a quick interview of the finance chairman. And so we did that, had a good conversation. I'm really excited about where we're going with some of this, and a little trepidation about some of the stuff about the CARES Act funding. But I think we really got the right team that's going to help us on that in terms of how we account for it. And so anyway, just give everyone a heads up. I think it's December that we actually get the audit. Is that correct, Sharon?
Yes, it'll be early December is when the Finance Committee meets because of the holidays.
Okay. All right. So that's, I think, all important but good stuff. Let's move on to item 5A, which is Ms. Clark giving us the financial report for August.
Okay, we're going to bring up the financials real quick. Just as an introduction, the medical center had a strong month again for the month of August. Much of the same reasoning that we've had the last quarter. Volumes look very consistent with last quarter, and I will cover those. Let me see. Having a little trouble advancing my slides. Here we go. Okay. So we have the admissions where if you look at the blue bars, that's kind of our current fiscal year trend. You can see where we dipped way down in April, and we're beginning a slow recovery on our admissions, about the same as prior month. patient days follow the same trend. Our case mix index at the bottom left of your screen continues to be much higher. We're about 7% above our budget, and that was about equal to last year. So we're seeing that the patients that we do have in-house are at a higher acuity. There are more things wrong, and they're a little bit more severe. However, we have also been trying to get patients out of the hospital as soon as possible. So our length of stay is actually about 5% behind our budget plan. Typically, you would see those two correlated, but because of all of our extraordinary efforts for patient safety and for also throughput, we're able to focus a little bit on length of stay. When you look at our emergency department, again, pretty much the same for the last 2 or 3 months. We're consistently seeing almost 9,000 a month through the ED. And at the bottom left, you can see in urgent care, we're seeing around an additional 2,700. And those volumes within urgent care are starting to recover. Now, although these are small, you do have these on your board portal. We have revised based on some discussions in the last finance committee about what exactly is happening in telehealth. So we are going to permanently revise this slide for our primary care and our specialty care visits. You'll notice a little striped portion on the current month bars. The striped portion is representative of the number of telehealth or phone call visits that we're having with patients. The darker blue bar is actually the face-to-face within a clinic setting. So I think this gives you a really good idea visually. The majority of those patient touches that have occurred since March are virtual visits. If you look at the primary care, we have had, for example, in August, we had 14,000 telehealth visits and 8,000 face-to-face. So about 65% of our total visits are within the patient's home. If you drop down to that specialty care graph, not as many telehealth visits, but still a significant amount at about 40% or 7,000 for the month. I've got a special slide for you that is not in your packet. And again, this is just drilling down to show you a little bit more some of the complexities and the differences between some of the avenues that we conduct telehealth through. The right slide is representative of scheduled appointments. Now, scheduled appointments impact both the medical center and a claim. And you can see that, again, the telephone visits are in the darker bottom part of those bars, and the audio visual is in the top part. So right now we're doing more through telephonic. Sometimes our patients have challenges with technology. We're also still standing up and getting optimize the telehealth platform. In next year's budget, those have flip-flopped. We're going to try to do much more virtual with video than the telephone, but that's how it's occurred for the last few months. And then the right-hand side of the page is actually urgent care or unscheduled appointments, where a patient calls in and they get routed to a physician who is working the urgent care video that day. Those visits do not affect the medical center, but are only counted in a claim. Now, these charts have very different numbers attached to them. So the scale on the right is 30,000 visits. The scale on I'm sorry, I said that wrong. On the left is 40,000, and the urgent care scale is about 400. So don't let the scales fool you. So I just wanted to point that out, that they are very, very different volumes. Are there any questions? Okay.
Sharon, will you include that slide going forward?
I wasn't planning on including the telehealth activity at this level of detail. If you guys would like me to continue to do that, I can. I did plan to permanently modify this primary and specialty slide so that you can see the telehealth versus the face-to-face.
Yeah, I think that's good.
Okay. Some of our other key statistics, we have observation cases that remain high. Our invasive lab procedures on the top right are returning to normal. So you can see in April we were extremely low, and now we're ramping back up to pre-COVID volume. Our surgery visits are the two graphs at the bottom of the page. Inpatient has just about, although we're below budget for the month, we've just about returned to normal volumes for inpatient. And as we start to open up our outpatient surgeries, you can see that we are increasing that month over month from the time that we had to start shutting down those surgeries in April. So we'll continue to open those up slowly and steadily. Our next slides are for our mental health business. Psych patient days continue to be right on budget, and the psych emergency visits at the bottom right of the page continue to be fairly high and equal to prior year levels. Those visits have not really been impacted since April. At the top, we have our clinic visits, and I've modified our psychiatric clinic graph to reflect the same information that our specialty and primary care graphs have. So again, you can see the stripe portion is going to be telehealth, and the bottom part of that bar is actually our face-to-face. We have had to modify, from my understanding, the way that we conduct our clinic visits, because a lot of our mental health visits are done in group settings. So all of those had to be moved to a virtual platform. Our financial picture is still very strong. Our days cash on hand is at 321 currently. Our net AR days is down to 35 days in August. I will tell you that there's a bit of a math problem going on here. As our revenues start to increase, it does have an impact, and it lowers our net AR days. So as we start to even out our revenues, I will just tell you to expect our net AR to creep up a bit and become a little bit more normalized, hopefully around at the 40-day mark as it was before. And then our FTEs per adjusted patient day continues to be unfavorable. This is the 11-month year-to-date look. Our outpatient volumes are so far down, as well as our inpatient volumes have been under budget this year. So that again is the effect of the lower volume. Are there any questions so far on the graphs? I've gone through a lot this morning. Our payer mix slide, this again is year to date. We maintain a similar payer mix. I will say that our self-pay is at 18%, and our connection is at 19%. So typically the combination of those two is right at 40%. So that slight change in our payer mix is creating some of the price variance that you see on the face of the income statement. It only takes a percentage or two to go from no payment, and this is gross revenue or charges. When this graph shifts by just a percent, it's a nice pickup from a collection percentage side on the next slides. Our JPS connection enrollment, I have a couple of things I wanted to talk to you about. We are looking at how to touch the community in different ways since COVID occurred. We have had kind of a virtual application process. We will take applications in many forms, including a drop-off at some of our traditional locations. But we have begun to see an uptick in applications. Typically, we were receiving anywhere from 100 to 150 applications a day. This month, we are up to 250 to 300 applications a day. So we are going to, next week, start to staff those offices. We're not going to conduct face-to-face visits, but it does give the applicant a chance to come drop off either their application or some additional information that is required. So we are diligently working through those applications. And I just wanted to let you know, I had worked with Michelle Haynes, our director over the eligibility function. And on average, there's about an 11% denial rate on these applications. So we are disqualifying some on those, but 31% of those are requiring follow-up. 31% of our applications for additional information, and 58% are typically approved very quickly. So, and the high note, go ahead, I'm sorry.
No, I'm sorry, I interrupted you, go ahead.
Oh, no, I was just going to say the high note is in September, we have kind of crossed over that 44,000 member mark. So, anyway, we haven't talked about connection in detail in a while.
Yeah, the numbers really jumped out at me that you just said. 150 applications up to now to 300. That's a 100% increase.
Yes.
In applications.
Just for this month, you know, we have trended a much higher. I think a combination of things. We all are aware of the economic impacts that COVID has had on our community. We've planned for an uptick in connection in the 2021 budget. People are also getting out more. And I think as you get out more and you start to access care more, the connection enrollment becomes more of a focus for people.
Sharon, this is Reverend Emerson. On those denials, something just hit me. On those denials, do you have categories to see where the largest group is that the denials are taking place?
I did not get that information from Michelle for today, but I can definitely bring that back next month. Well,
the reason I asked, not so much to bring back to the board, but that might be also an area that she would want to share at our meeting so that those pastors could maybe look at how they can help deal with that particular area.
You bet. That's
I think that's yeah, this is Amanda. I think that's important information also to bring back to the board to let us know so that we can also see what the community needs are. And if there's other modifications within the Connections program or other programs, then that would be very helpful information.
Okay.
Thank you.
We do try to make that application as user-friendly as possible. So this is the financial performance for August of 20. Our income from operations was just over $10 million compared to about a $5 million budget. Most of that increase is up in the net patient service revenue line at the very top of the page. And this is a little bit, it's lower because of volume. And then we have an increase because of that payer mix graph that I was showing you. We have had some programs that have really helped us throughout COVID, where self-pay patients would not be, we would receive zero, but we've got some HRSA funding. Medicare has also increased the payment rate for a COVID positive patient by about 20%. So we have had some nice price variance this month with some of our activity. We also are seeing some savings in salary, and our benefits are also slightly below budget, which is our own employees accessing health care. One of the larger savings that we've had is in our purchase service, and with the lower clinic volumes that are occurring, we have had lower claims payment as well, and that's been a trend since March. Year to date, our actual performance is about $71 million compared to about a $56 million year to date budget. So our partners in a claim, they have experienced about a 17% decline from budget, and that's trending year to date. If you look at year to date, they're about 14% under budget in encounters, which typically trend with both our inpatient activity and our outpatient activity. And when you look at their income from operations, they came in at about a $3.7 million loss compared to a $2.3 million budget. Year to date, that brings them to about $36 million. Again, the driver here in a claim is they're not having those reduced expenses. Most of those are our providers who are also doing telehealth work. And we do have a negative impact from that conversion over into telehealth from a financial standpoint. We do get a lower reimbursement than we do for a face-to-face. Are there any questions on either the medical center or a claim? Just to point out, year to date, our income from operations on a consolidated basis is about $36.3 million. We do have, like I mentioned earlier in the presentation, one more month before we final close the year, and you will see those numbers at the next Finance Committee.
Any questions for Sharon on this? Okay, I'll entertain a motion to accept the August report.
Move approval.
Second.
Yeah.
We have a motion and a second. I believe Charlie was second on that. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, Sharon. I think you're still up to bat for item B.
I am. This is a policy which we are recommending to be archived. This policy really was, well, it was written back in 2013, 2012, 2013, when the waiver program first started. And some of the language, as you read through here, is really outdated. The policies and the way that Tarrant County operates and we IGT has totally changed since then. We've really incorporated that into both our budget process as well as the creation of the LPPF that the board votes on annually, at least annually, if not more, on setting tax rates and collecting dollars from the hospitals here in Tarrant County so we can make those IGTs. So after review, my recommendation is that we archive this policy.
Sharon, most of the time, a policy in place like this is an accountability measure. So and obviously this is outdated because the world has changed since 2014, but in your professional opinion, this doesn't dilute any accountability from this board or from administration, correct?
Correct. We reviewed it with Adams, Lynch, and Lofton. There are other controls and other approval processes that the board complies with, and we didn't feel like a separate policy was required.
Okay. Any other questions for Sharon on this? Okay. Entertain a motion for approval of item B as presented by clerk.
This is Zim, move to approve.
Motion by Mr. Zimmerman.
I'll second it.
Second by Dr. Weber. All in favor, please say aye.
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 Opposed? Motion passes. Thank you, Sharon. Item C.
I'm going to turn it over to Rory for, oh, I'm sorry, C is me. Rory doesn't want to talk about the ECRI contract. So the next item up is for ECRI is a supply chain tool. It's key in benchmarking. Although our GPO contract does a great deal of benchmarking, it's only benchmarking for those GPO vendors. So ECRI allows us to go out to the market, and it's for capital, it's for PPE purchases, any kind of purchase, even some service contracts. This is about $225,000 annually. There is a 3-year term with a small implementation fee for a total of $637,000.
Questions for Sharon?
Yeah, can you put it a little more in basic English exactly?
So this is kind of like a database that is created, and whoever, if we were to go out and buy sonograms, we would be able to see what other people blinded were paying for sonograms from that particular company. It also is a basis for not only pricing of capital and making sure that our vendors are giving us their best price, but it also has a component for recall management that is integral to what we do in supply chain and safety.
What do you mean by recall management?
So if, much like if you have a home warranty or anything, if there's ever a product recall on supplies that we have purchased, it will notify us, and we have processes here at the medical center where those products, if they've already been distributed out of the warehouse, we actually pull them back. So with a lot of medical devices, with sometimes everyday things, there are recalls issued by the sellers of those products where we're having to go back in and retrieve them.
Okay, gotcha. Thank you.
Mm-hmm.
Question for Sharon? Okay. Now, entertain a motion on item C.
Recommend approval.
A motion for approval by Dr. Weber.
This is Zim.
Second.
For a second by Mr. Zimmerman. All in favor, please say aye.
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 Opposed? Motion passes. Thank you, Sharon. Next two items are going to be Rory. and I like them both a lot. So, Roy, you're up for item D.
All right, thank you, Mr. Chairman. We have a couple items this morning to discuss both related to managed care contracting. JPS is always striving to put ourselves in the best position with contracting, particularly in behavioral health as demand continues to rise for those services. We've had some great work take place by Kelly Ford and her team. Cammie Jones is part of that team. And we also appreciate Zilia's leadership. Particularly, she was very good at pushing us to maximize reimbursement as well as our relationships with the payers. So strengthening that service line as we can. The first item D is related to Cigna. Cigna Behavioral Health, that covers all product lines for Cigna, including HMO, PPO, self-insured, and others. We were able to negotiate higher reimbursement with this agreement. And as you know, negotiations can often be challenging, and obtaining increases is often difficult. So we're proud of the work that's been done there. Any questions on Cigna?
Questions for Rory?
No.
Okay, we'll take these one at a time. Item D, I'll entertain a motion on that one.
So moved.
Motion by Dr. Weber.
Tim, second.
Second by Mr. Zimmerman. All in favor, please say aye.
Aye.
All opposed, same sign. Motion passes. Thank you, Roy. Item E.
Okay, this item E relates to Humana Military. This is more commonly known as the TRICARE product. You may hear it referred to as TRICARE. So it covers our active duty and retired, as well as Guard Reserve members. This agreement allows us to be in network for behavioral services. We were previously out of network, so those patients that presented to our ED were often having to be approved out of network. So we're thankful that we're able to serve these members and have less hurdles for them receiving care. As far as why we were not in network originally, there was really not a paper trail on that. We believe it was just inadvertently left out. So we've got the behavioral portion included now with the regular medical care. So questions on Humana Military TRICARE?
Questions for Rory? Hearing none, I'll entertain a motion on item E.
Mr. Chairman, I'd move for approval.
Motion by Mr. Powell.
Dorothy, I second it.
Mr. Dubose seconds. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, Roy, very much. Great work. Item F, the contract owner, new guy, Mr. Lane, has asked we pull that one down temporarily. I think he's scared. He thinks we're going to haze him. So temporarily hold on that one. Move on to item
Dr. Duncan. Yeah, I think I did
Ms. Peebles.
hear him a little bit.
You could still have him come up just for the heck of it. I mean, just...
Yeah, that's true. Thank you for being here. Item G.
Good morning. I'm here this morning to ask your approval for a master terms or for an addendum to the quotation that we currently have. We have an agreement, a master terms and conditions agreement with GE. So this is just an amendment to that agreement. Having trouble talking this morning. This is for our anesthesia machines, and it's to replace our fleet of anesthesia machines that are currently 7 to 10 years old. So we will be replacing 24 of those. This was approved in our capital budget this year, and we're also asking to upgrade 3 of those machines that are currently in we want to go ahead and upgrade those, even though they're not that old, so that they are all standardized for safety purposes, and all the anesthesia machines would be the same for those. This is part of our Vizient contract.
That was probably Robert Early that made that rude noise. Thank you, Wanda. That was great. Great explanation. Any questions for Wanda on that item? Okay, hearing none, entertain a motion on item G.
Move approval.
Motion by Ms. Dubose,
Second.
second by Dr. Weber. All in favor, please say aye.
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 Opposed? Motion passes. Thank you, everybody. Item
David,
H. Yes.
David Mendenhall, could you fix the screen? Because Steve Montgomery is frozen on it, and it's starting to scare the staff. So if you could freeze him.
I wish there was a fix there, but October 31st is coming soon.
I understand.
Anyway, before we were so rudely interrupted, Wanda, item H.
Okay, my next request is another addendum to a master terms and conditions contract with GE. This is to replace our monitors in our preoperative area. If you remember, we've been slowly changing out our monitors throughout the system. We had previously changed out the ED and the ICU and critical care areas, and we're continuing to go through and standardize those monitors throughout the organization. So we're asking to replace 21 of our cardiac monitors in our pre-op area. These are also on our Vizient contract and approved in our capital budget. Our current monitors that we have in this area was purchased back in 2008. So they are at end of life, and Biomed is no longer available to get parts for those. Any questions?
Hallelujah.
Mr. Chairman, it sounds much needed. I make a motion for approval.
Okay, we have a motion by Mr. Powell,
Second.
second by Dr. Weber. Before we move on to any other questions for Wanda on this item? Hearing none, we have a motion and a second. Everyone in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, Wanda.
Thank you.
Moving to item I, Zelia Bamaball.
Good morning, members of the board. I'm here today to present to you an interlocal agreement between JPS and MHMR of Tarrant County. It's a request for JPS to provide MHMR 2,000 flu vaccines for the adult psychiatric patients of MHMR of Tarrant County at a total cost of $33,000. Both JPS and MHMR jointly share this patient population, and we believe with our vaccination program here at JPS and allocating these 2,000 doses to MHMR, we can better vaccinate for the flu, for this upcoming flu season, that could potentially reduce ED visits as well as hospitalizations for this vulnerable patient population. So I'm asking for your permission and approval. Thank you.
Thank you, Zelia. Any questions for Zelia?
Move approval.
We have a motion by Reverend Emerson,
Second.
second by Mr. Zimmerman. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Zelia.
Thank you. Thanks, everybody.
Thanks.
And finally on our list, item J, Dr. Elliott. Thank you for bringing a little class through our program this morning. Item J.
Well, good morning. Good morning. Thanks for having me this morning. So I'm very excited to actually present to you this collaborative agreement that we have in considering approval for our SAMHSA grant. And this is an agreement between Integrative Emergency Services, IES, and Tarrant County Hospital District. You've probably heard a lot of great things that we actually received our very first federal grant funded by the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. This is an incredible achievement for us. It was a collaborative, definitely, between JPS. We had the Office of Clinical Research with Dr. Acosta's team, the Center for Outcomes Research with Dr. Oja's team, Foundation with JR's team, Behavioral Health with Zelia and Dr. DeMoss, Pain Management with Dr. Teams, and our IES, Dr. Jim Detienne, who is also now a PI on this, and then one of our Center for Outcomes Research faculty, Dr. Mersada Serdarovich will be also the two PIs on this, co-PI. So we're excited about this. It is a $1.5 million grant over a 3-year period, meaning about $500,000 annually over 3 years. So this agreement actually is an agreement between IAS to be able to provide what we need to do for this grant. Will be $361,270 paid annually to IAS. This will be an annual agreement, renewable, automatically renewed over those 3 years period. That budget could be adjusted based on the needs of the grant, but that is the first agreement that we have for this year. So we'd like to present that to you for approval.
Nice. Sounds like a very collaborative, a lot of great minds involved. I didn't hear Mr. Early's name in that list, so I'm encouraged that it may actually be successful. Any questions for Dr. Elliott?
I'd just like to add, this is a huge thing focused on opioid management, which we know is a crisis we see across the country, and the fact that we're actively engaging and looking at alternatives for this and medication-assisted programs, it'll be a big win for us and our patients and our community. Thank you.
Fantastic. Fantastic. Any questions for Tricia?
There goes
Mr. Chairman.
All right, Reverend Emerson, I believe I heard you.
Oh, no, I was just going to move approval, but I had a question for Dr. Elliott after the motion passed.
Yes, sir. I'll hang on.
So we have a motion for item J. Do I hear a second?
Second.
Second by Mr. Zimmerman. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Reverend Emerson, you have the floor.
Yeah, well, let me apologize to Mr. Early and Dr. Duncan for this question, but since Dr. Elliott was on the agenda, it triggered this question. And looking at Dr. Oz's show the other day, he been really moving on dealing with the lack of minorities in the healthcare field. And I was just wondering if we could generate such a meeting to talk about that, especially the last time you were at board meeting, I mentioned that the HBCUs have a real strong program in trying to get more minorities into healthcare, and especially since it's so glaring with the COVID situation. And I just wondered if we could talk about how we could generate some connections with the HBCUs here, or how we can generate something out of JPS. So I just wanted to put that. But I didn't talk to Robert or Dr. Duncan ahead of time, so I'm sorry. So
that is not a problem
fine.
at all. Thank you, Reverend Emerson. We'll be happy to bring that forward. We're doing some very active work on that, and we'd love to even hear more ideas around that. This is a passion of mine around diversity, equity, and inclusion, and looking at advancing our underrepresented in medicine pipeline, physician pipeline, particularly, and in healthcare all over. So this is a passion for mine. We have some strategies we're trying to do. It's a long-term strategy because it doesn't happen just in 1 year, but we are looking at ways to partner with our HBCUs. We actually work also with our Student National Medical Association. I recently just even talked to our local panel of that. We've got a regional SNMA meeting. Even last year, we had several of our residents attend the Student National Medical Association conference. We've had students actually go up to Howard University, did a presentation around JPS up there. We are doing another regional SNMA conference and participating and highlighting all of our programs on a virtual conference next month. And so we're looking at that. We're also looking at the Latino Medical Student Association, looking at all opportunities to get the word out there about what we do here and really looking at that pipeline. I'll tell you, it's a national issue because we know the pool, unfortunately, is low across the board for medical schools. The pool is only about 8% Black and about 6 to 7% Latino, other underrepresented even less than that. So we are looking at ways to try to look at that, but with a small pool, how can we even get part of that pool to get here to JPS and highlight what we do here with our community? So I'll tell you, I'm also active in a lot of national movements around moving the URM pipeline. So I'm happy to share that that work that also I'm trying to do nationally to make sure that that brings that also for us here at JPS. So happy to bring that forward. I'm hoping to be able to do our annual institutional review, which now kind of got delayed with COVID. And I'll work with Robert and Dr. Duncan to look at timing for that for you.
Okay. Thank you.
Anytime.
Pastor Emerson, the other great thing that we have, and I know it's a direct response to your question, is during the HR committee, we're going to be introducing some of our new team members. We will reprise that and bring it to the full board, but we have a new individual coming in to head up our diversity and inclusion office. We're really excited about his arrival to JPS. Parkland's loss is our gain, and we are excited by that. So we think we're going to be able to have some really good new ideas coming into our organization. And with Tricia Elliott and the team trying to look at the pipeline of residents coming into the process, so that maybe in a couple of years, that pool is not at 8% and 6% for Hispanic and African American leaders. Maybe that pool's 15%. Maybe that pool's 20%. Maybe that pool gives us a better ability to recruit. We're pretty excited about the possibilities. And I will tell you that the efforts of Tricia Elliott are amongst a few in the nation that have vocalized that in a really strong way. And I think it's being heard. So your point's well taken. And Dr. Duncan and I agree wholeheartedly. And that's why Tricia's in the position she's in.
Thank you.
You're welcome.
Thank you, Reverend Emerson. Okay. Without further ado, we'll go to item 6. Mr. Hartsfield, how are you this morning?
I'm doing well. How are you?
Doing well, thank you. Anything to report on contracts?
Yes, for the month of August, there were 37 contracts negotiated on behalf of the district under $500,000, and that report is in the portal.
Okay, any questions for Corey on those? Okay. I don't believe, Counselor, we have anything in closed session. Are you aware of anything?
I'm not.
Okay. I don't believe we are. So with that, we will, no further business. We are adjourned.
Okay. Well, good afternoon. Let's go ahead and call the Human Resource Committee to order. Do we have any citizens wishing to address the committee?
Nope, no one signed up.
Okay. Then the next thing on our agenda is the minutes. Have everyone had an opportunity to review the minutes?
Move approval.
All right. It's been moved by Steve. Can I get a second?
Second.
Okay. It's been moved and second to approve the minutes as printed. All those in favor signify by saying aye.
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 Opposed by nay. Okay. Being no opposed, they are approved. The next on our agenda is consider approval of the HR 5000 return to work with medical restriction policy. Who's presenting? Okay.
Who's got it?
Who's got that?
Must be Robert.
Okay, Robert.
We were trying to make sure that we are getting our minutes down. So I clicked off for 1 second. I'm sorry, Madam Chair, where are we?
Okay, we're on HR 5000 return to work with medical restriction policy.
Wouldn't that be Alex?
I thought it would be Alex. Is Alex with us yet?
Yes, he is. He just got on board.
Yes.
If I'm not mistaken, I don't know, and I'll refer to legal counsel on this one. I don't think there are major changes to this. It's the same policy that we have had in place. It's a re-upping of it. I think it's just word changes, Madam Chair. I don't think there are any changes on here, and I'll defer to legal counsel, but I know that this went through, and I just think it's word updates. There are no new policy changes to this policy.
Yeah, I think that's right. I don't think there are any substantive changes.
Okay. Are there anyone have any questions? Okay, then I will entertain a motion for approval of the return to work with medical restriction policy.
Recommend approval.
Okay.
Second.
All right, it's been motioned by Chuck, second by Amanda. All those in favor signify by saying aye.
Aye.
Any opposed by nay? Okay, that one is approved. Our next one is personnel records, HR 4600. I didn't see anything on that one. It looks like to me it's just needed to be up.
Yes, ma'am. It is in the same category as the last one. Those are just updates. And again, if I am speaking out of turn, legal counsel, but it's my understanding that is just an update and a refresh and bringing it up to speed in the order of policies.
I believe that's correct.
Thank you.
Are there any questions on that policy?
I do have a question for you.
Okay.
On the last sentence and how it reads, it says all temporary and contract workers, and that has parentheses travelers. That doesn't have anything to do with people that we have that are doing contract work for us.
They are
employees, correct?
So the contract workers or travelers, those could be nurses, etc.
Right.
They will have some form of a personnel record.
Correct, but it says all temporary and contract workers, and we have the parenthesis travelers. But could anybody read that as contract workers, such as people putting in the new bushes out front, that type of thing? I'm just curious.
I don't believe they would. Yeah, no, I think that is why they've referenced travelers under contract workers, that those people putting bushes out front would have a contract that they're working under, probably most likely to a vendor agreement.
Okay, and my second question is, do we have any other contract workers, i.e., like the travelers, that should be mentioned?
Not, Dr. Weber, not that I'm aware of, because you're going to have two categories. You're going to have a contractual vendor relationship, and you're going to have those that are considered your travelers. So to Alex's point, I don't think there's any other contractual relationships we have other than the ones that are under a vendor contract or those that are under a temporary traveling basis, such as our nurses. I don't think there's anybody that's left out of that category. They're going to fit in one of two boxes.
Very good. Thank you.
Are there any other questions? Okay. Then there being no further question, I'll entertain a motion for approval of HR 4600.
Recommend.
This is Jim.
Okay, I think Steve motioned it, and Chuck, will you second it?
Yeah, I'll second it.
Okay. All those in favor of HR 4600 signify by saying aye.
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 Those opposed by nay. All right. Listen, I'm trying to beat Steve's record, so you might hear me rushing you a little bit. Okay, Alex. Alex, you're up for turnover report.
Get early to start making those noises, and we'll get out of here early.
Well, Mr. Bowles, I will certainly try and speed the plow here. Thank you. The turnover report, which you all have, I'll just call your attention to total voluntary turnover in the upper right-hand corner. You can look at the most recent quarter at 13.31%. You can see our benchmark is at roughly 12%. We're not too far off there. And the good news is that you'll notice that our one-year turnover moved from 38.36% back down to 33.7%. Now it's not quite as good as the first quarter of this year, but you'll note that sometime at the late first quarter and second quarter, something called COVID hit us, and that certainly made the spike. So we are heading in the right direction as it relates to turnover. Okay.
Alex,
Any questions on that?
Yes, ma'am.
Go ahead, Steve.
And I know this is maybe not a fair question because the ink isn't dry on your employee pass, but can you kind of highlight, or maybe next time or at some point in time, highlight some of the strategies that we're employing to reduce these numbers? Because this is such an expense to the institute, to the organization, as you well know. High turnover is. Maybe you can at some point update us on what strategies we're using to bring those numbers down.
Sure will. And I will say this to you, Ms. Montgomery, that as I speak to colleagues across the country, a great deal of what's driving that high one-year turnover rate are the millennial population. Now, we are discussing strategies on how we...
Amanda, he's talking about you, okay?
A couple different lines on that one.
But
it's my youthful facial regimen that keeps me so young.
But I will circle back to you at the next meeting and share some of those strategies with you.
Alex,
thank you.
Alex, I
Absolutely.
think at one of the other meetings, Roger Fisher had asked for some type of comparison data. How we relate to other institutions, et cetera. Is that available?
It is. It's in the top right corner of this document under the benchmark. You'll see the quarters. You'll see what our benchmark is. And when coming to that benchmark data, we do look at other organizations. Now I can, if you're interested in specific organizations, I can try and secure that information from specific organizations local here in the local Texas market. The best, I think the best comparisons will be in our local marketplace and not necessarily nationally, but it's important to look at the national trends as well. And I would also add that this is probably, one could argue it's a good year to look at it or a bad year to look at it. But I think I'd let us get a little bit past COVID before we take a serious look at some of this data and begin to either create strategies around it or draw conclusions from it. I think there's just an upheaval in the healthcare space right now, and we all know why.
Okay.
Well, Alex, go ahead, Amanda.
Oh, I just had one kind of follow-up question with the millennials. It would be interesting to see, since you have some benchmarking on support services that are total turnover at 30%, and which of these areas are you seeing that turnover within those age ranges? Is that what's causing that? Is that one of just the ideas of movement, or is it specific to the area that they're working in?
Yeah, I think wherever, a great question, Ms. Arizola, and I'll answer it this way. Wherever you see some of the lower paying roles, you will see higher turnover.
Yeah.
Wherever you see roles where there is not a great deal of career path available, you will see higher turnover.
And that's why I was curious. This is Roger. That's why I was curious about the comparison to other institutions as well.
Yes.
Especially locally.
Understood.
Didn't know you were there, Roger. Sorry.
Sorry, I'm on the phone today, sir.
Okay.
And I will certainly circle back to you in the next meeting. We'll try and get you some additional local data, which I think will be relevant. I think you will see similar numbers. Everyone may define their support services slightly differently, so I may look at some job categories for you to give you a better sense of how we compare. But again, wherever you see low wages and lack of career path, you're going to see higher turnover.
That's like board service.
Similar numbers is the best news.
Okay. All right. Well, we'll put that on for our next meeting to have that data, and if we can, Alex, I know we just won't focus on COVID, but go back at least 2 years if you can. Okay.
Yes, I will.
Right.
Thank you, Mr. Bose.
Okay. Anyone else have any comments on the dashboard? Okay. All right. I kind of want to ask y'all if you want to go into closed session before we do the leadership, because I think they were going to give us a little bit more information on our art chart before we do that. Are y'all okay with doing that, or do you want to just go according to the agenda?
I'm okay with it.
You okay with us?
I'm okay.
Yeah, I'm fine with closed.
Closed, okay. All right, okay, so what I'd like to do at this time now is for us to go into closed session to discuss personnel matters and et cetera, okay?
Okay, Ms. Dubose, give us just a couple of minutes to cut the stream and I'll be right back with you.
we will go back into open session at 1:30 to complete a couple of our agenda items. We will start by the announcement of the new leaders that will be joining the hospital district.
Yes, ma'am. We are looking at bringing on a group of executives that we think will make a great effort to take JPS to even higher levels. We've been receiving nice accolades in the last year. We've had a team that has done some incredible work, particularly in light of COVID. We have people that come into this building every day that literally put their lives at risk. And so we think we're going to be adding to that team in good ways. Alex Dubose will be coming on as our Senior Vice President of Human Resources. We are proud to have Alex be part of the team. We are having Dina Dent come on as our Chief Nurse Operating Officer, and she will be coming in as our CNO. And we are very impressed with her. As I mentioned, she's coming and joining us currently from Baton Rouge. And then we have Daphne Walker, and Daphne will be coming on. No, let me go in order here. Charles Horn. Charles is joining us from Parkland, and Charles will be coming in as our Vice President of Diversity and Inclusion. And I think Charles will add a great deal to our organization. And I think he'll pick up when Michelle retired, I think Charles will pick up from those efforts and bring on some additional ideas for us. The next individual that we have coming on board is Doug Chung. Doug is actually a native of Dallas, but has spent his most recent career years down in Kingwood, next to Houston at an HCA facility. We liked him because of his background in the emergency room and creating a stand-up ER at that facility, and some of the work that he's done in lab and respiratory therapy. We think that he's going to be a really nice addition to us. And then we have Daphne Walker joining our team. Daphne is joining us as our in-house counsel, and she will be part of the team. I know that you board members had the opportunity to meet her at our last board meeting. She is joining us with some 17, 18 years in the healthcare industry. It's also a neat situation for us that she's actually an Arlington resident. So she knows JPS well. And I think that the fact that we found a strong candidate who started her career as a nurse and then went into the legal profession really speaks well of her abilities. And then Wanda Peoples, and Wanda will move into the role of Chief Nurse Executive and dealing with regulatory and survey preparation from a nursing standpoint. She'll be looking at where JPS heads in the future, if it wants to go and look at magnet status, and we will inform the board of whether we want to approach that. And it will give Wanda the ability to take more of an oversight role of nursing and allow Dina to do a lot of the actual operations. So we are excited, and board members, you will actually have the opportunity to meet those people in person when you come to the next board meeting. So we're very much looking forward to that. And I want to thank you, Ms. Dubose, for your role in chairing the HR department. And I want to thank you all as board members, allowing me to have the leadership to bring what I think is a really good team on board. And the last thing that I will say is that Dr. Karen Duncan has made some wonderful improvements to this team. And the relationship that she and I have as COO and CEO, in my opinion, has been phenomenal. And that's because of Karen. She is a really good person to work with, and she has good ideas, and she is not for any form of standing still in any form. So I think she will bring JPS to higher levels, and I really appreciate our partnership that we have developed. She's an incredible asset, and I really appreciate working with her. So Ms. Dubose, that is our team, and that is our group, and we hope that that will be a team that we can take into the future. And you're starting to look at the next generations of JPS's leadership, and we're excited by them.
All right. Well, thank you, Robert. Do any of the board members have any questions? Okay. Well, thank you. Then our last item is we completed Mr. Early's evaluation at our last HR committee, and we need to have one more recommendation so that we can move forward with him receiving his merit increase. So I'm looking for a recommendation to take to the full board.
Madam Chairman, I'd like to move to grant the CEO a 3% merit increase. This will date back, retroactive back to October 1st, 2019. And this will allow the CEO to be current regarding his merit.
All right.
I'll second that.
Thank you. It's motion by Ralph, second by Chuck. Is there any questions or discussion?
Ms. Dubose?
Yes.
Real quick, I just want to make a comment, really more or less for the record.
Okay.
That because there will be newspaper articles written about this, especially in a time like COVID, that this is a retroactive deal that covers the period of time prior to COVID.
Yes.
And I think that distinction is important to note prior to our voting.
Okay. So you are recommending we change the motion to
No, I just want to be for the record to state before the Star Telegram says, you know, in COVID we're giving Robert this gigantic raise, that this is covering the period of time prior to COVID.
Okay. All right. Okay. Any other discussion? All those in favor signify by saying aye.
Aye.
Any opposed by nay? All right. Listen, I'm not going to apologize because all of you do a great job, and we just can't do it as fast as that finance committee that's spending all of our money. So
spend it.
There being no further business, we are adjourned, and thank y'all a lot. I really appreciate it.